year in India, there are 12.7 million annual cases of tonsillitis. The recurrence rate, that is patients experiencing multiple episodes annually, both pediatric and adult, is around 23%, and the complication rate of 17.3% is seen in patients developing tonsillitis in the form of the peritonsillar abscess or cellulitis in the neck. So that is the complication rate that we see in India today. So what is the anatomy? As you all must be aware, there is a group or a ring form of lymphoid tissue in the nasopharynx and the oropharynx, which is known as a Waldeyer's ring, and this consists of a central portion of aggregation of lymphoid tissue base in the nasopharynx, which is central, only one in number, and that is known as the pharyngeal tonsil, or commonly known as adenoids. Then on the lateral walls of the nasopharynx, besides the opening of the eustachian tube in the fossa of Rosenmüller, we see another aggregate or band of lymphoid tissue, which is known as the tubal tonsils. Then we have the palatine tonsils, which is commonly, when we speak of tonsillitis, we are only concentrating mainly on the palatine tonsils. So palatine tonsils are also known as the tonsils or the fascial tonsils, and they are between the two arches of the palate, which is formed anteriorly by the palatopharyngeus muscle, palatoglossus muscle, and posteriorly by the palatopharyngeus muscle. So there are groups of lymphoid tissue, and then we have an aggregate of lymphoid tissue in the posterior part of the tongue. So whenever you see the tongue by a tongue depressor and you see the posterior part of the tongue, you see a lot of follicles. Actually, those are the lymphoid aggregate on the base of the tongue, which is known as the lingual tonsil. So these are the four groups: the pharyngeal tonsil, the tubal tonsil, the palatine tonsil, and the lingual tonsil. They are the first line of defense for the immunity of any individual, because they will produce lymphocytes and also are active in the synthesis of immunoglobulins. So these are the normal tonsils. So what is the location of the tonsils? Is located mainly in the oropharynx. It's not in the oral cavity, it's a part of the oropharynx. So there is a soft palate, there is a uvula in between, and then between the two arches, the anterior pillar and the posterior pillar, we have this aggregate of lymphoid tissue both on the right and left side, which is the palatine tonsil or the tonsil. So they are ovoid in shape. Laterally in the oropharynx, they are bordered deeply by the superior constrictor muscle, anteriorly by the palatoglossus going from the palate to the tongue, posteriorly by the palatopharyngeus muscle going from the palate to the superior, the pharyngeal lateral wall. Superiorly there is the soft palate, and inferiorly there is a lingual tonsil. This is the blood supply of the tonsil. It is mainly through, so in the neck we have the common carotid artery, which will bifurcate into the external and the internal carotid artery. The internal carotid artery mainly does not give any branches in the neck or on the face region. It goes directly to the brain, and then it will give the ophthalmic artery, which will then divide into the anterior and posterior ethmoidal arteries going into the nasal cavity. But otherwise the internal carotid does not have any branches here. Mainly the branches to the tonsils go from the external carotid artery through its various branches, that is the facial, lingual, and ascending palatine arteries. And so these are all the various branches of the three main branches of the external carotid. So we have the tonsillar artery, we have the ascending palatine artery, we have the tonsillar branches of the ascending pharyngeal artery, and then we have the descending palatine artery, which is a branch of the maxillary artery. So all these are the branches of the external carotid artery. The venous outflow is by a plexus around the tonsillar capsule, and then we have the lingual vein and the pharyngeal plexus. The lymphatic drainage is mainly to the superior deep cervical lymph nodes and the jugular digastric nodes, and the sensory supply is to the glossopharyngeal nerve and the lesser palatine nerve. So this is now I'm talking about the adenoids, which is the central lymphoid tissue in the nasopharynx, and the tonsil or the palatine tonsil, which is located in the oropharynx. So grossly, it's the adenoid is triangular in shape and it has fewer crypts, whereas the tonsil is ovoid in shape and it has multiple crypts. That is indentation within the substance of that lymphoid tissue, and the largest crypt in the tonsil is known as crypta magna, and it is the presence of the crypts and collection of food and the exudate and the bacterial debris which will be seen on the surface of the tonsils. So again, the epithelium is different. So in the nasopharynx, the two lymphoid aggregates we have in the nasopharynx are covered with the respiratory epithelium, that is ciliated pseudostratified epithelium, whereas those present in the oropharynx, that is the tonsil or the palatine tonsil and the lingual tonsil, will be covered with non-keratinizing squamous epithelium. So the epithelium differs both in the nasopharynx and the oropharynx. So tonsillitis is the inflammation of all these lymphoid aggregates. The inflammation usually extends to the adenoids and the lingual tonsil. So commonly the term pharyngitis is used because it will involve both the nasopharynx and the oropharynx lymphoid tissue. What is the microbial etiology? So in 68% of the cases it is bacterial infection, and the most common is the group A beta hemolytic streptococcus or GAPHS. The second most common is the Staph aureus, then H. influenzae. Viral infections make around 27% of the cases, the most common being adenovirus, less common the EB or Epstein-Barr virus and the rhinoviruses. Fungal infections are around 3% of the cases, Candida and Aspergillus being the two most common, and certain idiopathic causes make 2% of the cases. So this is the pathophysiology of infection within the lymphoid aggregates, and basically in the palatine or the tonsillitis, how the infection occurs. So there will be a microbial invasion. Either it can be an inhaled or an ingested microbial infection. So the pathogen will colonize in the tonsillous crypts and the surface epithelium. There will be the body response, the inflammatory response in the form of neutrophil recruitment and the cytokine cascade activation. Then there will be within the lymphoid tissue, the germinal center will start, there will be a lymphoid hyperplasia there, and so there will be B and T cell proliferation within the tonsillar tissue, and because of that there will be clinical manifestation in the form of edema, erythema, exudate formation, and various systemic symptoms like fever. So this is the clinical classification of tonsils. What do we call acute tonsillitis? So it is a rapid onset of severe odynophagia or painful swallowing. There is tonsillar exudate, there is fever more than 38.3 degrees centigrade, and tender cervical lymphadenopathy, and this is usually less than 2 weeks duration. So that is acute tonsillitis. As per classification, what do we call recurrent tonsillitis is more than or equal to 7 episodes in the past year, or more than 5 yearly episodes for 2 consecutive years. So the episodes are similar to the acute tonsillitis infection, and there will be periods where the patient is asymptomatic in between, and so there will be, the child will be going to, mainly when we speak of the pediatric population, the child will be going to school for a month, then there will be a break for 10-12 days, then he will be alright going back to school. So there will be such episodes recurrently seen. Chronic tonsillitis is any persistent symptom for more than 3 months, and again chronic tonsillitis, when we say the number of episodes, we say it should be more than 3 episodes per year for 3 consecutive years. And then the clinical symptoms will be halitosis or bad breath, tonsillar crypts will be seen with debris, there is persistent sore throat and tonsillar hyperplasia. the tonsillar enlargement or hyperplasia can cause obstruction also. So it will be obstruction in the nasopharynx, oropharynx, or it can be a combined one. So this is how we say, this is a very basic picture showing how to differentiate between a viral tonsillitis and a bacterial. So that if you feel it is a viral, there is just redness, swollen tonsil, and there is some redness in the posterior pharyngeal wall or in the oral cavity, you consider this to be viral. Just take some painkillers or paracetamol and do salt water gargles and just stay at home. But if there is some bacterial infection in the form of the uvula being swollen, there is spots over the tonsillar tissue, the swelling of the tonsil, there is generalized redness of the throat, and there is a coated tongue, you consider this to be a bacterial infection and treatment is required by a doctor.
So basically, if there is a white spot, you can label it as
Yes, if there is an exudate, then you have to consider it to be a bacterial infection. If it is a viral, there won't be an exudate seen. It will be generalized redness only. So acute tonsillitis, I won't go into this again. So there are various types of acute tonsillitis. Again, catarrhal or superficial tonsillitis, mainly seen in viral infection. So it's a generalized pharyngitis. Follicular, whenever a doctor puts it as follicular tonsil, acute follicular tonsillitis means it is a bacterial infection. So there is a spread into the crypts, purulent material presenting at the opening of the crypts as a yellow spot. Acute parenchymatous again is a pathognomic of a bacterial infection, and membranous is when there is an acute follicular tonsillitis and all the exudates will coalesce and form a membrane, or in certain cases we very rarely see, but diphtheric infection will again form membrane on the tonsil, very rarely seen. These are few pictures of the superficial or acute catarrhal viral tonsillitis. This is follicular tonsillitis, and this is acute membranous where all the exudate will coalesce and form the membrane. Again the signs, same: halitosis, coated tongue, congestion, jugular digastric nodes are enlarged and tonsils are congested and enlarged. So I'll take the treatment part later, but complications of acute tonsillitis is chronic tonsillitis or recurrent tonsillitis. It can form a peritonsillar abscess, there is parapharyngeal abscess, cervical abscess. It can cause acute otitis media, it can lead to severe problem like rheumatic fever and acute glomerular nephritis. So I don't think we'll go into this. Chronic tonsillitis is complication of acute tonsillitis. Again, the subclinical infection of tonsil, chronic sinusitis and dental problems can also cause chronic tonsillitis, mainly affects children and young adults also. So in chronic tonsillitis, there are recurrent attacks of sore throat, chronic irritation in the throat with cough, again halitosis, dysphagia or dysphagia, and thick speech, which we know as a hot potato speech because of the enlarged tonsils. There is not proper closure of the palatopharyngeal muscle, so there is a nasal escape of the air. So it's a hypernasal speech. So you feel the patient is speaking through the nose. This is one very important sign which is known as a Irwin-Moore sign. So whenever we give pressure on the anterior pillar, there will be some expression of pus from the crypts of the tonsil. This is a sign of chronic tonsillitis. So treatment of tonsillitis is again conservative or medical management, and in certain cases it can be surgery which is tonsillectomy. The main pharmacological management, like we said, in 68% of the cases where bacterial infection is there, it is by group A beta hemolytic streptococcus, and the main treatment for that streptococcus penicillin. So what we use now is amoxicillin and combined with the clavulanic part. So we use amoxiclav. Amoxicillin, if you are using plain, it is 40 to 50 milligram per kg per day or 500 milligram TDS. But here the main important thing is the duration. So you don't give it for 5 days or 7 days. You have to treat it for 10 days. If the patient is allergic to penicillin, then the treatment is a macrolide, and preferably it should be azithromycin, 12 milligram per kg per day or 500 milligram OD, mainly for 5 days duration. Analgesics, you can use paracetamol and QID, and anti-inflammatories when needed, ibuprofen in the dose of 400 milligram TDS in adults. Like I said, the tonsillitis, acute, even acute, recurrent and chronic tonsillitis have complications in the form of peritonsillar abscess, parapharyngeal abscesses, retropharyngeal abscess, intratonsillar abscess. There can be formation of tonsillar cyst. There can be a lith, or a tonsillar lith is a stone within the tonsil whenever the exudate becomes solidified, and mainly these are calcium crystals only. So there is these stones which are formed within the tonsillar lymphoid tissue, that is known as a tonsillar lith. And the main treatment for all these, whether it be peritonsillar abscess, parapharyngeal abscess, retropharyngeal abscess, cyst or a tonsillar lith, these are all surgical managements. So again, when we talk of infection, tonsillitis is infection, but tonsillar hyperplasia can cause obstruction also. Like I said, it can be nasopharyngeal, oropharyngeal or combined. So airway obstruction may manifest as mouth breathing, snoring, sleep, disordered breathing, nocturnal breathing pauses, or even sleep apnea. And because of the disturbed sleep, there may be lethargy and malaise present. So recurrent streptococcal tonsillitis is diagnosed when you have 7 culture-proven episodes in 1 year, 5 infection in 2 consecutive years, or 3 infection each year for 3 consecutive years. So this chronic tonsillitis is 3 infection each year for 3 consecutive years. Then only we say it is a chronic tonsillitis. And then in most cases, chronic tonsillitis have a surgical role, important surgical role in the form of tonsillectomy. So like I said, peritonsillar abscess will present with very severe throat pain, fever, drooling, foul breath, trismus, that is difficulty in mouth opening, and altered speech, that is the hot potato speech. So this is how we do the examination of the oral cavity and the oropharynx. First, just examine orally, then you put the tongue depressor and see the oropharynx. What is the role of flexible endoscopy? Only in very selected patients when you feel that the pharyngitis is extending lower down, causing some involvement of the epiglottis or any respiratory or breathing problems, you might do an endoscopy to rule that out also. So in peritonsillar abscess, there will be pharyngeal edema and trismus, and there will be very tender lymph nodes. So this is a picture where, because of the enlarged follicular tonsil and they were causing respiratory distress, and no medical line of treatment could immediately resolve it. This was a case for tonsillectomy. Palatine tonsil, again, peritonsillar abscess. This is usually the picture where you see it is usually unilateral. Very few cases of bilateral peritonsillar abscess are seen. So usually it is on one side, and that entire side will be pushing the coming medially, and it will push the uvula to the opposite side. So throat cultures are the criterion or the standard for detecting group A beta hemolytic streptococcus. So this is how the American or the Western medical line of management or goes. So whenever the child or an adult with tonsillitis goes to a clinic, so what they do is they do a rapid antigen testing like we used to do for the COVID. We do a rapid, within 15 minutes you get the report, and then you say that okay, if it is negative but you are still suspecting tonsillitis, then you do a throat swab or a throat culture. But if it is negative, you treat it as viral and just give paracetamol and salt water gargles. So this is how they practice in the Western countries. Here, everyone treats it as bacterial. So when you don't try to differentiate at all whether it is bacterial or viral, you treat it as bacterial. So everyone from the primary care provider to a specialist will give an antibiotic. So we don't follow all these criteria. Only in certain cases where some line of management has not given positive results, would somebody do a throat swab and try to find out what is the culture and the organisms looking like. So this is actually, these are the guidelines, but in India we actually don't follow any of these. So this rapid antigen detection test, also known as the STEP test, detects the presence of group A beta hemolytic cell wall carbohydrate from the swab material, and it can be done easily. 15 minutes is the turnaround time for that test, and it is but it has a specificity of 95% or more, and it produces a result in less time. But a negative rapid antigen test still means that you have to do a throat culture.
Here.
No, sir, nobody, even the ENT specialist would not do a rapid antigen test. So certain times when we see that, and imaging, routine imaging is usually not done. So we don't even do a plain X-ray of the neck for tonsillitis. Yes, in recurrent or chronic tonsillitis where you are expecting an obstruction because of the hyperplasia or hypertrophy of the adenoids. Because see, adenoids usually start growing from birth up till 5 years of age. So the obstruction part because of adenoids is usually seen in up to 5 years of age children. So whenever they come, they usually have the breathing problem. So the parent or the mother would complain that when the child speaks, there is a lot of sound coming. So when you want to see the obstructive part, then you do a X-ray or maybe in certain cases a plain CT to see how much of the obstruction is there, because the nasopharynx is a very small space, and if the adenoids are hypertrophy, it will cover up the entire posterior nares. So whatever the child will not be able to breathe through the nose at all. So it will all be oral breathing. So to know the extent of obstruction, yes, we do X-ray or a scan. But yes, for peritonsillar abscess, it is a clinical diagnosis. Even that, in those cases, we don't do a scan. But yes, if you are expecting a deep cervical abscess, a parapharyngeal or a retropharyngeal abscess, because of as a complication to the tonsillitis or pharyngitis, you would go for a scan. Again, here this is what I was saying. So because I work with the oncology part also, so if we suspect that the tonsils are enlarged but they are asymmetric, or you see a tonsillar enlargement mainly on one side only, then it raises a suspicion that this might not be part of an infection, it might be something else, because it is lymphoid tissue. Okay, so whenever we get a node in the neck and that node does not subside, unilateral node does not subside with antibiotic treatment, and if we do a FNAC and that shows a suspicion of metastasis in the neck, then the first, or that is known as a metastasis of an unknown origin, that is what they give on the histopathological or a cytological report, then there are these areas which we will go in and examine endoscopically. So that will be the nasopharynx to see for both the tubal and the palatine nasopharyngeal tonsil, and then we will do and C for the lingual tonsil and the palatine tonsil. And in cases where we feel that only a unilateral tonsillar hypertrophy has occurred, I have done lots of tonsillectomy to remove that single lymphoid aggregate and send it for histopathology, and in most cases it has come as lymphoma. So same corticosteroids, I don't think many people use it in active infection, but yes, for chronic infection, for hypertrophied tonsils, maybe there might be a role of corticosteroids. I have not used it very frequently. I am not very sure how many medical professionals would be using, but that is a no. It is given in the guidelines, but I have reservations about that. So, indications for tonsillectomy, according to the American Otolaryngology and Medenic Society, is enlarged tonsils that cause upper airway obstruction, severe dysphagia, sleep disorders, recurrent peritonsillar abscess, unilateral tonsillar hypertrophy, which is presumed to be neoplastic, and chronic tonsillitis or recurrent tonsillitis and permanent. These are all indications for tonsillectomy, either in the pediatric or in the adult. Contraindications to tonsillectomy: any bleeding disorders, anemia, acute infection, uncontrolled, and other medical illnesses. How do we do tonsillectomy? We usually put the patient in a roses position. There is a shoulder roll beneath his shoulder. You extend the neck, and the patient is lying on the table. We usually stand on the head end. So it is not, we are not facing the patient, we are standing on the head end. So the patient's right is my right and his left is my left. It's not the mirror image when we are standing in front of the patient. So we have a mouth gag, which is known as a Davis Boyle mouth gag, and we suspend the oropharynx. And how do we do the surgery? So whenever this is the roses position, and how do we do the surgery? Either by cold steel, scalpel, curette, scissors, and all the instruments, or you can use monopolar cautery. But monopolar cautery in tonsillitis is basically not advisable, because if the bleeding is there, and it is a severe kind of bleeding which is not stopped by either pressure or a tie, then it is mainly from the tonsillar artery, which is a branch of the external carotid artery, and in those cases it's better to use a bipolar cautery. So monopolar cautery is a no-no for tonsillectomy. Another instrument which is frequently used for tonsillectomy is a radiofrequency ablation or a co-ablation. And it is mainly used, so it is a very low temperature ablation using plasma and saline. So you try to dissolve the lymphoid tissue, mainly used for the adenoids very frequently. I have not used it for the tonsils or the palatine tonsils, but yes, since so many years, because I was working in an institute where we had one of the best CO2 laser machines, and I was already trained at Mumbai using CO2 lasers. So I have always done my tonsillectomy using laser, the CO2 laser, and sometimes the harmonic scalpel also. And they give very good results, very less blood loss. So it is, when you use a CO2 laser or a coablator or a harmonic, the blood loss is less than 40 to 50 ml. So these are various, this is how you stand and do the surgery. And the complications of surgery are hemorrhage, which is the most common. It can be intraoperative, which is primary or occurring within the first 24 hours, and secondary hemorrhage between 24 hours and 10 days. So the first 10 days you can have bleeding following tonsillectomy. Again, pain after surgery is possible. Dehydration in children if they don't eat because of pain or don't drink fluids. Fever is not very common, but if there is any local infection, it can cause fever. fever as a post-operative complication for tonsillectomy, and post-operative airway obstruction because of the uvula edema. So in most cases, post-tonsillectomy, we always give hydrocortisone 100 milligram or 200 milligram depending on the weight of the patient, because whenever we use all these instruments to open the oropharynx, there is some edema of the soft palate and the uvula because of the use of the instrument. So it is best that we give hydrocon immediately post-op. So that is a common practice everywhere. And there can be local trauma to oral tissues. Sometimes if you open the oral cavity very hard, there may be temporomandibular joint dislocation, physiological or psychological trauma, nasopharyngeal stenosis. So coagulation sometimes can cause nasopharyngeal stenosis because of excessive removal of the lymphoid tissue and the surrounding mucosa also, and then the healing occurs by fibrosis, so there can be a chance of stenosis. Death is very uncommon because of tonsillectomy. Bleeding is one of the complications or can be a complication of anesthesia. So thank you so much for your